Hi, my name is Darwish, professor and consultant of obstetrics and gynecology. In this lecture, I'd like to highlight some controversial and new indications of diagnostic hysteroscopy in modern practice. You know that all of us use hysteroscopy for diagnosis of intrauterine adhesions or intrauterine lesions that may affect fertility or may cause abnormal uterine bleeding. Our team and others published a lot of publications on the use of hysteroscopy for diagnosing and treating uterine septum, polyps, fibroids, adhesions, and otherwise. But in this lecture, I'd like to address some diagnostic implications that are either controversial or new in the clinical practice. The first controversial issue is to use hysteroscopy prior to ART or not, or during ART or not. If I use it, this will add some advantage of diagnosing endometritis, endometrial hyperplasia, impaired endometrial receptivity, some fine intrauterine synechia, endometrial polyps, uterine niche, and or ismocele, or other pathologies. But if I don't use, because it's an invasive procedure, it's costly and potential pain-related patient dissatisfaction, inadequate evidence-based studies supporting its use as a routine, and most importantly, 3D or 2D, high-resolution 2D or saline infusion sonography would offer great information regarding endometrial cavity and fallopian tubes. The second controversial issue is to use diagnostic hysteroscopy before the first IVF cycle because it is an expensive treatment, tedious, and psychologically the patient will have a lot of stress. So can I use it prior to the first IVF cycle or not? A meta-analysis and systematic review recently found that the diagnostic hysteroscopy improves the clinical pregnancy rate. However, the live birth rate is unaffected. And this was drained after evaluation of 12 studies of more than 5,000 patients. The second point is to use diagnostic hysteroscopy for failed embryo transfer access to the endometrial cavity. Yes, it can give you a significant importance or value with a significant reduction of clinical or improvement of clinical pregnancy rate. And actually, the failed access can be predicted by mock transfer. And we have a relatively recent publication on cervical canal negotiation using office hysteroscopy in patients with tight primary cervical stenosis in non-leprous women. The other controversial issue is to use hysteroscopy in cases of recurrent implantation failure, which is defined as failed embryo transfer with 3 cycles, both fresh and frozen, with no agreement on the cut-off upper age. And this recurrent implantation failure can be due to immunologic causes, thrombophilias, endometrial receptivity problems, microbiome, uterine abnormalities, male factor, or embryo aneuploidy. And if you look to these indications, you will find that endometrial receptivity and uterine anomalies can be evaluated by hysteroscopy. So hysteroscopy can add some information, but the evidence from the evidence-based studies found that outpatient hysteroscopy did not improve IVF outcome in patients with recurrent implantation failure with normal ultrasound of the endometrial cavity, particularly 3D or SIS, which may be due to high proportion of normal uterine cavity. But for uterine lesions that affect implantation rate, it's necessary to remove them before the next IVF trial. And hysteroscopy may be considered as a diagnostic and treatment option for infertile women who have experienced recurrent implantation failure, regardless of intrauterine pathologies, as mentioned in other publications. So it's a controversial issue to use or not to use. One of the controversial issues is hysteroscopic endometrial scratching, which is indicated in recurrent implantation failure after IVF, before IVF XZ, or as a treatment of unexplained infertility and in some cases of polycystic ovarian disease. And this scratching may lead to increased inflammatory, modulates desensitization by increased inflammatory infiltration, local production of IL-6 and TNF alpha, or unveiling or renewing adhesivity proteins at the endometrial surface. And the advantages of endometrial scratching is inducing a healing response with specific local inflammatory pathway changes, stimulating angiogenesis, and stimulating elements of the endometrial embryo crosstalk. But it is a painful procedure, invasive procedure with little evidence, as I told you. So randomized controlled trials of endometrial scratching may suffer from even more methodological issues with negligence of co-treatments, and there is insufficient evidence to support its use as found in some systematic reviews and meta-analysis. The recurrent pregnancy loss, pregnancy loss is involuntary ending of pregnancy prior to 20 weeks. And recurrent is a controversial definition. Royal College defined it more than 3 or more failed pregnancies, not necessarily consecutive, including clinical and biochemical pregnancies. The SRM mentioned 2 or more of failed clinical pregnancy and excluded biochemical pregnancy. The recent issue 2023 definition mentioned 2 or more failed pregnancies, whether clinical or biochemical, and do not include ectopic or molar pregnancy. These are controversial definitions of recurrent, and pregnancy loss is universally defined as less than loss of pregnancy prior to 20 weeks. So the controversies exist regarding recommendations for investigation and treatment of recurrent pregnancy loss. And the frequency of uterine malformation and endometrial disorders can be high in patients with recurrent pregnancy loss, including those with only 2 previous miscarriages, as mentioned in some publications. So individualized approaches should be created to recognize and correct any modifiable risk factors. What about unexplained infertility? We have a patient with unexplained infertility. Can hysteroscopy add some information? Yes, it can add, particularly evaluation of the endometrium regarding thickness, vasculature, color, and lesions, and fallopian tube functions by evaluation of tubal patency and peristalsis. And this has been published by our team in a book chapter in this book. Regarding endometrial thickness, actually it can evaluate the endometrial thickness by subjective evaluation. Is it normal, hyperplastic, thickened, or atrophic? And we can use a simple hysteroscopic endometrial thickness test by going with the telescope to the fundus and then make pressure on the posterior wall when you are coming out with the instrument to make a furrow. If the furrow is deep enough, this can signify endometrial thickness or thickened endometrium, but if there is no furrow, this is a thin endometrium. Also vasculature, we can evaluate congested endometrium, BTK, ecchymosis, bleeding on touch, or suspicious vasculature, in addition to normal evaluation, and of course color, pale, pink, reddish, or dark reddish, and lesions like polyp or masses. And these are subjective evaluation of the endometrium within normal, thin, thick, or hyperplastic, and its correlation to the ultrasonography and histopathology. Regarding vasculature, can be normal hairpin appearance of blood vessels in the endometrium, can be hyperemic or hemorrhagic spots or BTK, can be starry sky atrophic pattern, can be strawberry appearance, which may signify secretory endometrium, adenomyosis or endometritis, congested and bleeding on touch endometrium, or suspicious blood vessels, as you see in this photo, with dilated tortuous black worm-like capillaries. So these are the vascular appearances. In this part of the lecture, I discussed with you the controversial issues of hysteroscopy in our modern practice. What's new? The new is to assess the fallopian tube via hysteroscopy. And the access to the fallopian tube is important to assess its functions. The first point is to know the intrauterine accessible part of the fallopian tube, and this can be evaluated by evaluation of three landmarks, which are diagnosed and reported and published by our team as Darwish hysteroscopic triad. You have to see three issues of the fallopian tube. Most of the hysteroscopists say that the tubal ostium is free or the tubal ostium is not seen and so on. The tubal ostium is just one of the three issues of the fallopian tube that can be seen by hysteroscopy. You can see the ostium as the most proximal part of the Darwish hysteroscopic triad. The triad is a cone-like shaped part of the fallopian tube, and the walls are the intramural part of the fallopian tube, and the summit is the dark spot of the ostium, which is the narrowest part of the fallopian tube. If you are oriented with this anatomic landmark, you can start to assess the fallopian tube properly and meticulously. If you just look to the ostium, you will never assess the functions of the fallopian tube by hysteroscopy. So we have three functions of the fallopian tube: the patency, the peristalsis, and ciliary epithelial movements. Actually, by hysteroscopy, we can assess tubal patency and peristalsis only. Tubal patency and peristalsis. And you know that the proximal part has peristalsis towards the ampulla, and the distal part, peristalsis from the fimbria towards the ampulla to help the oocyte to go to the site of fertilization. And the proximal part takes the sperms to the site of fertilization. This should be put in mind while you are starting to assess the functions via hysteroscopy. Now, the first function of the fallopian tube is patency. And patency can be assessed by what's called bubble tests. Bubble tests can be assessed by observational bubbles going to the triad by like suction mechanism. And these are the passage of air bubbles towards the Darwish triad to ensure that the patient has some patency by hysteroscopy. Sometimes you do have a patient with negative bubble tests that is due to either anatomic causes like polyp, like this case, the bubble cannot cross due to the presence of polyp in the Darwish triad, and it protrudes towards the endometrial cavity. That prevents passage of air bubbles, or due to some endometritis or some endometrial lesions like this case, and the bubbles cannot cross the Darwish triad. So the bubble test in such a case is negative, and the first case was positive. Now, you can observe not only bubbles, you can observe passage of debris, some endometrial shreds, some blood clots, and this is called flow test. So you can find bubble flow test or flow test, which is passage of endometrial debris or endometrial shreds, blood clots through the Darwish triad, and this may signify patency of the fallopian tube. I told you we have distal peristalsis and proximal peristalsis. Distal peristalsis cannot be seen by hysteroscopy. Hysteroscopy evaluates only the proximal part of the fallopian tube, and the distal part can be tried to be assessed by laparoscopy, and we recently published a publication on laparoscopic diagnosis of distal peristalsis, and actually the results were disappointing due to failure of assessing the distal peristalsis despite anatomically normal fallopian tubes. The second function of the fallopian tube is peristalsis, which is rhythmic contraction and relaxation of the proximal part of the fallopian tube and the Darwish triad. And this, if you see this view by hysteroscopy, while you are observing it for some time, This signifies that she has positive peristalsis. So the second tubal function is good. This case has peristalsis, positive peristalsis, and there is an intratubal polyp. This polyp is not endometrial polyp, it is intratubal polyp. And due to peristalsis, you will observe with frequent peristalsis of the proximal part of the fallopian tube that this polyp is extruded into the endometrial cavity. Now it is completely intratubal. It is not in the endometrial cavity, but with peristalsis, the polyp comes out into the endometrial cavity. This ensures that there is peristalsis that pushes the polyp to come to the endometrial cavity and to be intrauterine. Firstly, it was intratubal, and now it is intrauterine, and this is another case. Also, this is a peristalsis. You can observe peristalsis of the proximal part of the fallopian tube, again, as I told you. So the second function can be assessed by hysteroscopy is peristalsis. If we combine bubble test and peristalsis, this is called Darwish test, and we studied this test in a previous study on healthy fallopian tubes and hydrosalpingeal fallopian tubes, and found that combination of bubble test and peristalsis achieved high diagnostic accuracy if compared to either test alone. So this is a new or a novel indication of hysteroscopy is to assess the fallopian tube functions via hysteroscopy, and this can be achieved only if you put Darwish hysteroscopic triad in your mind. The second novel indication in cases of abnormal uterine bleeding, you know, the classification of abnormal uterine bleeding as PALM coil. If you look to PALM is an acronym of polyp. So the first and most important indication of hysteroscopy in abnormal uterine bleeding is to diagnose polypi, adenomyosis, leiomyoma, malignancy, and these are indications of hysteroscopy due to structural causes that may explain abnormal uterine bleeding. Functional causes, endometrial causes like endometritis, like endometritis or problem of the vasculature with endometrium, or iatrogenic due to drugs. And we studied the hysteroscopic use of abnormal uterine bleeding and found that office hysteroscopy is an important tool for diagnosing abnormal uterine bleeding. And without its use, half of the focal lesions could be missed, and office sitting and one-stop approach facilitates the procedure and make it easy and accessible. And the combination of office hysteroscopy and TVS in addition to endometrial sampling can give us good results in a study of around 300 cases. What about the use in cases using progesterone-only contraceptives or progestins? We know that progestins are either progesterone derivatives, testosterone derivatives, or spironolactone derivatives. We can use the hysteroscopy in all these methods causing abnormal bleeding, unexplained abnormal bleeding. We can use it for medroxyprogesterone acetate injections. We can use it for testosterone derivatives, desogestrel and Cerazette, for example, etonogestrel in implanon, levonorgestrel in Microlot and Mirena, and norethindrone acetate in 350 microgram tablets, and also in spironolactone derivatives in 4 milligram new drospirenone containing pills. We studied 140 cases with abnormal bleeding, unexplained bleeding with progestogen-only contraceptives, and found that, and compared to patients submitted to hysteroscopy due to other indications, particular infertility, and we found that the endometrium in the patients with abnormal bleeding with progestogen-only contraceptives is significantly affected if compared to control group, and the functions of fallopian tube are impaired if compared to the infertility or control groups. This means that the progesterone may have an effect on the proximal part of the fallopian tube as a mechanism of contraception, in addition to endometrial changes. And this study has been recently published. And we actually designed an algorithm for management plan of abnormal uterine bleeding and progestogen-only contraceptives regular users. We have to start by transvaginal sonography. If suspect polyp, go to 2D sonostrography, and if confirmed, you can do hysteroscopic polypectomy, or to do 3D without sonostrography. If you find polyp, you have to do polypectomy. But if you see ovarian cyst by ultrasound, you have to give her hormonal contraceptive pills. If no cysts, you go to hysteroscopy. If she is using levonorgestrel intrauterine system, displaced or malrotated, removed or extracted, well placed, you can do his office hysteroscopy. So hysteroscopy has a lot of indications in all methods of progestogen only contraceptive pill contraception, and actually it's rule after exclusion of organic causes. And if the hysteroscopy showed abnormal endometrial vasculature, you can give tranexamic acid, diazepam, or non-steroidal anti-inflammatory. If normal endometrial vasculature, you can give systemic hormones like estrogen, COCs, norethindrone acetate as a recent implication in such cases. One of the new indications of hysteroscopy is prediction of endometrial carcinoma by observation of desquamation, atypical vessels, white or yellow lesions, which were significantly predictors for endometrial carcinoma in a recent publication. An additional new indication of or implication of hysteroscopy is to use chromohysteroscopy. I advise you to use chromohysteroscopy in all cases of infertility or recurrent pregnancy loss. Why? Because normal endometrium does not stain with methylene blue, because it is non-absorptive epithelium and does not take the stain. So if you inject dye inside the endometrial cavity and this and the endometrium is stained, this is abnormal endometrium, either pathologic or injured or damaged part of the endometrium. So better to do hysteroscopy after laparoscopic chromoperturbation, as mentioned by our publication on which procedure ought to be done first, laparoscopy or hysteroscopy. And this is the chromohysteroscopy showing a fundal transverse line, which is called Darwish line, signifying maybe abnormal endometrial development, or it is a site of development of endometrium, which starts from cervix towards fundus anteriorly and posteriorly. And we see it often, and actually we already commented on this line, and this can be seen here. And also in pathologic endometrium, this can be also stained with blood without methylene blue, and this is the appearance of this line without dye, and this is after dye here. And actually, we took biopsies from this site and found it is pure myometrium, not covered by endometrium. That may signify that it is not part of the endometrial cavity. Actually, it may be a signified site of fusion of the endometrial creeping to uterine cavity in intrauterine life. And actually, we recently published this as a chromohystoscopic documentation of a transverse fundal endometrial defect, which is called Darwish line. And this is found also in PubMed. In conclusion of this lecture on controversial issues and novel issues of diagnostic implications of hysteroscopy, we have to mention that hysteroscopy is not just an intrauterine endoscopy. It is a multifunctional tool. You have to widen the scope of its use. Detection of delicate intrauterine endometrial and vascular chains with or without dye use is considered an in vivo study of the uterus, particularly in cases with recurrent implantation failure, recurrent pregnancy loss, or infertility. And proximal fallopian tube function testing is an easy additional benefit of hysteroscopy in infertile women if you put Darwish hysteroscopic triad in your mind. Thank you so much.